So good morning. Today we will be discussing your laboratory evaluation in hematology. Okay. So we will be focusing on your red blood cell indices. So your red blood cell indices composed of your MCB, MCH, MCHC, and then your RDW. Okay. This red blood cell indices is being correlated with your hemoglobin. Okay. The hemoglobin content and the size of the RBC. So for your MCV, okay, it is the indices that define the size and hemoglobin content of your RBC. Your MCHC focuses on the hemoglobin concentration, while your mean corpuscular hemoglobin or your MCH, same with your MCHC. It correlates the hemoglobin concentration inside the RBC. This help determines the specific types of your anemia. These results no can help us to differentiate different types of anemia. Okay. So for your MCB, indicates the mean or average volume of a red blood cell. Okay. So the volume correlates also the size. Okay, individual cell size. Okay. We do have the variation in size, which is known to be your anisocytosis. Okay. Okay, this is best for classifying your anemia, especially those who are correlating in the size, like your hemoglobin C, hemoglobin S. Okay. Then the index expresses the volume occupied by a single erythrocyte and measures in cubic micrometers or even in femtoliters. Okay. So this is the mean volume. So what is the normal value for this? We do have 80. We do have 80 to 100 femtoliters. Okay, it's the normal value for your MCHC. Lesser than 80 femtoliters is equals to your microcytosis. Okay, this results to your microcytosis. While your greater than 100 results to macrocytosis. Okay, then if it's within the range, okay, within this range, it is called a normocyte. Okay. So the formula for your MCB, hematocrit in percent times 10 over RBC in millions. Okay, the RBC count. Okay. We can correlate this MCB with your microcytic anemia, very small size anemia. Okay, which range to your 50 to 80, but we note that the 80 is normal still. This 82 is a borderline for your microcytosis. What are this disorder under this microcytic anemia? You can see these microcytes in your iron deficiency anemia or your EDA, anemic of chronic diseases, then congenital hypochromic microcytic anemia with iron overload. So it correlates with your also with your iron content of your RBC. Okay. Even your normocyte, okay, also has a correlation with some diseases. Even if it's normal, it still has some diseases that manifest your normocyte. So what are those? Okay, anemia with appropriate bone marrow response. like your acute post-hemorrhagic anemia. So after the um, hemorrhage, your body is now trying to compensate the loss. No? So it will have a normocytic type of anemia. Okay? Normocytic normochromic. Same goes with your hemolytic anemia. Appropriate. No? Normal pa rin yung bone response mo. Okay? Unlike with your anemia with impaired bone marrow response, this has a abnormality or defect in your bone marrow. Okay? Like your marrow hypoplasia, which results to your aplastic anemia. Your aplastic anemia is the difficulty, no, or um, difficulty or your defect, defect in your um, cell production. Okay, you have a defect in your cell production, which results to anemia. Okay, your bone marrow doesn't produce enough blood cells or normal blood cells to your body, okay, to compensate with the normal body circulation. Okay, this happens in some exposure to radiation. To radiation, no, it changes the bone marrow um, bone marrow response. Okay. Next is your marrow infiltration. Infiltration by malignant cells like your myelofibrosis. Okay. Decreased erythropoietin production, your kidney and liver disease, which is the main organs that produces your EPO. Okay. Endocrine deficiencies, malnutrition, chronic anemia, chronic disease of anemia of chronic disease. Okay, this produces decreased EPO. No, your EPO is responsible for the production of your red blood cells. Right, it is the hormone that signals the production of your RBCs. That's why when this EPO is being depleted or not normally produced, you do have a certain type of anemia which is manifested by your normocytic normochromic anemia. Okay? Next is your macrocytic anemia, greater than 100, value greater than 100. Okay? Sometimes caused by your cobalamin or vitamin B12 deficiency. Okay? Or even decreased ingestion of the some minerals like your B12, no? Vitamins and minerals. Even in competitive parasite infestation, okay? Like your tapeworm, no? Especially your Dipolybotrium latum. Okay? Your dilatum, no, competes with your body in RBC. Okay? This parasite ingests your RBC. Okay? So, um, you will have, no, anemia. Okay? Decreased RBC, no, which is manifested by macrocytosis. Okay? Also, your folate deficiency results to macrocytic anemia. Okay? So this vitamin B12, your cobalamin, and folic acid or your folate, results to macrocytic anemia. Okay? Decreased vegetable intake for your folate is present in high dose, especially in your vegetable. And your alcoholism decreases the um, decreases the absorption absorption of your folic acid. Okay? That's why alcoholism can cause certain type of your anemia, which is your macrocytic anemia. Next is your MCHC, or your mean corpuscular hemoglobin concentration. This measures the average concentration of your hemoglobin inside the cell. Most valuable in monitoring therapy for anemia. Okay? Especially those with cancers. Okay? Mas importante ito sa mga doktor. If ever na your patient is a cancer patient, okay, to continue and stop if ever the chemotherapy. Okay. So the normal value is 32 to 36 gram per deciliter. Okay. The formula is hemoglobin times 100 over hematocrit in percent. Okay. Then this MCHC is decreased, when your RBC doesn't contain enough hemoglobin. Okay? If it's high in hemoglobin, it will have a high value. Okay? So your hypochromic anemia, so this MCHC also correlates to your color of your RBC. Okay? The color of your RBC. Okay? Hypochromia. Okay? Hypochromia and hyperchromia. Okay. For your hypochromia, hypochromic anemia, the value is less than 30. The borderline for your abnormal MCHC is 30. Okay, which is manifested by your iron deficiency anemia. Okay? Microcytic anemia. Chronic blood loss anemia. Why? For this, decrease in hematocrit. Yeah. Hematocrit, no, no, this results to decrease hematocrit like your microcytic anemia. Okay? So, hyperchromic anemia naman, or hypochromasia, is greater than 36 gram per deciliter. Okay? Which signifies your increase in hematocrit. Next is your MCHC. Formula for this is your hemoglobin, in gram per deciliter times 10 over your RBC count. This is increased in association with your macrocytic anemia. Decrease with association of your microcytic anemia. This can also be used in determining the size of the RBC, like your MCV, size of the RBC. Okay. Factors that can interfere or falsely elevate your MCH is your hyperlipidemia. When your lipids are too high in the blood, this can cause increased MCHC levels, especially in your automated techniques. Okay. Also, high heparin content can also elevate MCHC. That's why the preferred um, anticoagulant for you in this RBC indices are your ethylene diamine tetraacetic acid, or your EDTA. Okay? RDW, okay? RDW has a normal value of 11.5 to 14.5. Okay? This correlates to your RBC size. Huh? This can also be used in investigation of some hematologic disorder and monitoring response to therapy, especially those um, cells with abnormality in the cells shape. Okay? So the indication of degree of anisocytosis is the RDW, a red cell distribution width, okay, which correlates to your size of the RBC. Okay, your red blood cell indices, no, is helpful in distinguishing uncomplicated heterozygous thalassemia, especially your MCV. Okay, thalassemias. Your thalassemias are correlated to have defects with certain chain in your hemoglobin. So, um, low MCV can distinguish your thalassemias. Okay? Next, this is not under your red blood cell indices, but additional test for the maturation of your RBC, which is reticulocyte count. So your reticulocyte count or retic count, no, assesses the erythropoietic activity of the bone marrow. Okay? So the erythropoietic activity is the maturation or the production of your RBC. Production and maturation. Okay, what is the process of this? You will obtain whole blood, no, using anticoagulant with anticoagulant of EDTA or your ethylene diamine tetraacetic acid, no, stained with supravital stain. Okay, your supravital stains are being used to stain live cells. Okay, such as your new methylene blue and brilliant crescel blue. Okay, so in counting your reticulocyte count, now your supravital stain will stain live cells, especially your RNA and organelles, remnants of your organelles. That's why the RBC will appear, no, with um, inclusions. Okay, inclusions of your RNA and organelles. Okay, because they take up your supravital stains. Okay, formula for this is percent. No? Your reticulocyte count is read in percent. Okay, this is for the number of retics. Okay, number of retics over 1,000 of RBC observed times 100. Okay, in every 1,000 RBC, you will compute for the number of your retics. Okay, so for example, you have 12 reticulocyte count. This is counted with 1,000 RBCs. Okay, so 12 times 100 over 1,000 is equals to 1.2%. So is that normal? Yes, because our normal range is 0.5 to 1.5%. So this is how a RBC or reticulocyte looks like, no, when stained with your supravital stain. Okay? So this blue, no, okay, inclusions seen inside the RBC or immature. Your reticulocyte count is reticulocytes are immature red blood cells. Okay, this is the last stage before going to a mature red blood cell. Okay, that's why this still has a RNA content or even organelles that are being, no, degraded before being matured. No, before they mature. Okay, yeah, the blue ones here. Okay, no? We do have absolute reticulocyte count or ARC. Okay, this is the actual number of your reticulocyte per 1 liter of blood. Okay, this is computed through your reticulocyte count in percent times the RBC count over 100. The reference range is 25 to 75 times 10 raised to 9 per liter. Okay, this is per liter kasi ang ina-assess nga natin is per 1 liter of your blood. Okay, for example, you do have 2% na reticulocyte count and an RBC count of 2.2, no? So your ARC will be 2 times 2.2 over 100, which is equivalent to 44 times 10 raised to 9 per liter. Okay? So, this is within the normal range, no, of your reticulocyte count or absolute reticulocyte count. Okay? We also have corrected reticulocyte count. Okay? This corrected reticulocyte count, no, may false is the corrected one which correlates to your falsely elevated whole blood, no, falsely elevated reticulocyte count that are falsely elevated because of your fewer RBCs. Okay? So, mataas daw yung count mo ng RBC, ng reticulocyte count. Bakit? Kasi konti yung RBC or mababa yung hematocrit ng patient. Okay. If ever, that your reticulocyte count is too high and the RBC count and the hematocrit is too low, you will use a corrected formula for reticulocyte count. Okay? How do we correct this? Okay, no, the normal formula for your corrected reticulocyte count is reticulocyte count na in percent times hematocrit over 45. Okay? So, why over 45? Because we consider the average normal hematocrit to be 45%. Okay? Reference range is 2 to 3%. Next, as said, now we can use reticulocyte count to assess the maturation of your um, RBC. Okay? So, this has a formula, no? Reticulocyte production index. Okay, formula for this is reticulocyte count times hematocrit over 45. No, as said, 45 is our baseline for we assume that this is the normal amount of your hematocrit. Okay, over the maturation time. So, what is the maturation time for your RBC? It is 7 days. So, your RBC are from your undifferentiated cell up to RBC takes 7 days, no, before it matures. Okay? Or RPI is also computed as 2 corrected reticulocyte count over the maturation time. So you do have the value for the time and days in maturation in correction factor. Okay, if this will be correlated with your hematocrit value. Okay, the hematocrit value in percent, no, if ever that the patient has 40 to 45, which is the normal count for your hematocrit content, no, will be 1 day. That is the correction factor. Okay, 35 to 39 will be 1.5. 25 to 34 will be 2. And 15 for 24, 2.5. And less than 15 is 3. Okay? The lower the hematocrit value, the higher correction factor that we will be using in the maturation time in days. Okay? In your RPI. Okay. Increased reticulocyte count are being seen with these diseases. Okay, and what are those? Your hemolytic anemia, lead poisoning, malaria, parasitic infection, blood intoxication, Alakazar, erythroblastic anemia, sickle cell anemia, relapsing fever, leukemia, splenic tumor. Okay. So these diseases, no, decreases your RBC count. How? Okay. Some of these diseases destroys your RBC. Okay. Some of this now prevents your red blood cell to be produced in the bone marrow. Okay. So if ever your RBC count is decreased, okay, your reticulocyte count is increased. Why? Your bone marrow is being stimulated to produce RBC. Okay? That's why it produces immature RBC in the peripheral blood. So you can see now reticulocytes in the peripheral blood. Worst case scenario, you will see younger RBCs in the peripheral blood. Okay? So, anong principle? No? Decrease RBC count, which is correlated to the destruction or decrease production of your RBC. Okay? While your decreased reticulocyte count can also be seen in aplastic anemia, acute benzoyl poisoning, chronic infection, anaplastic crisis of hemolytic anemia. Okay? Bakit? No? Bakit decrease ang reticulocyte count in these types of diseases? Okay, your aplastic anemia. And these three, no, decreases the production. Production of what? Of RBCs. That's why, if your production of RBCs are decreased, no, your reticulocyte count is decreased also. For reticulocyte is the cell before the maturation, full maturation to your RBC. Okay, aplastic anemia, no? No cells are being produced in your bone marrow. Your acute benzoyl poisoning also affects your bone marrow not to produce a cell, or it destroys the cells within the bone marrow. Chronic infections, okay, also decreases your RBC production, especially in your kidney and liver. Why? For the production of your EPO. Okay, anaplastic crisis of hemolytic anemia also decreases the production of your RBC. Okay, physiologic increase in reticulocyte count. So, reticulocyte count is not always abnormal, seen in abnormal condition. Now, we can observe this on your normal condition like your pregnancy, menstruation, and at birth. Why? For this, 3 increases the um, need for your RBC. Okay, this 3 increases the need for your RBC. Okay, so this decreases your increases the need for your RBC. Like in pregnancy, bakit? Dalawa na yung taong gumagamit nung RBC. The mother and the baby. And at birth, no? Increased production of your RBC. Why? Because it will now rely, no? The baby will now rely to its own production of these RBCs. And menstruation, no, in females, because of the loss, no, of blood, normal loss of blood, no, it increases need for the production of your RBC. That's why reticulocytosis can also be observed in physiological events. Next test for your RBCs are your erythrocyte sedimentation rate, or your ESR. Okay? This is the count, or this is the test that we assess the speed of fall of the erythrocytes to settle down, okay, from their plasma. Okay? This we assess how fast, no, the RBCs make a the packing, okay? The packing or the sedimentation in the bottom of the tube. Okay, this is useful in monitoring course of existing inflammatory diseases or differentiating between similar diseases. Okay, we do have some diseases that needs to be assessed using your ESR, like your inflammations. Okay, there are two ways in measuring your reticulocyte. erythrocyte count. Okay? So, we do have a, with the use of specific length of tube, okay, in with a specified period of time. Usually, this specified period of time is 1 hour. Okay? Or, now we do have another way which determines the time required to the RBC to reach specific point. Okay? So you will put a label, no? So for example, you do have in the tube, you will note that the RBC, no, will should settle in 20. Okay? How much time it will take to pack itself in the level of that 20 in the tube. Okay? So the other one is the period of time. The other one, the second way is using your specified point. Okay, which determines the time. Okay? So you do have phases and stages of in ESR. Okay? First is the agglomeration phase. Now this is the initial period of your aggregation. Okay? Few cells sink under gravity but majority form agglomeration. Okay? This also forms your rouleau. Okay? When you say rouleau, okay, this is the stacking of cells, no? Or sticking of cells within the other cells. Okay? Especially the variation of size. No? This usually um, forms rouleau formation. Okay? This takes place during the first 10 minutes of your ESR. Next is the phase of fast settling. Okay? The agglomerates, no, sink rapidly to the bottom of the tube. Okay? This rate falls depends on the size, again, of your RBCs. Okay? This takes place about 40 minutes. And then you have the final phase of packing. Okay? The rate of settling is low owing to the clogging of the agglomerates. Okay? Bakit bumabagal? Kasi dumadami na yung nag-agglomerates or nagpo-form ng rouleau formation. So, nagkakaroon na ng um, interference dun sa tube. Okay? This takes place during the last 10 minutes of your ESR. So your ESR is being assessed for 1 hour. Okay, 1 hour kasi 10, 40, and 10, which is equivalent to 60 minutes. Okay? So we do have methods in determining ESR. We do have macro using your Wintrobe Landsberg method, Westergren method, Graphic and Cutler method, no? Lenzerman method, Lenzerman method. Then you do have micro method, your Michaelan-Do method, Smith method, Halage-Vollmer method, or Krista method. Okay. Of course, we do have factors affecting your ESR count. Okay, we do have intrinsic factors like the plasma factor and your RBC factor. Okay, so this RBC factor and plasma factor increase in, so for example, your plasma factor is increased in fibrinogen. Fibrinogen, which no signals the cells to agglomerate. Okay, so for your RBC cell factor, we do have increase in size, no increase in size or decrease in size. Okay, increase or decrease in size can affect the ESR. Extrinsic factor, we do have mechanical factors like your vibration. Okay, your vibration can increase, no? ESRY, vibration can produce no movement of your RBC to set fast in the bottom of the tube. Technical factors, no, um increase anticoagulants, increase anticoagulants, no, can affect also your ESR, which decreases the time, no, of your ESR. Physical factors like your tilting of the tube can also affect your ESR. Okay, this can also increases your ESR. Okay, okay. Factors that increase the rate, no, as I said, no, intrinsic and extrinsic. We do have the plasma factor, yan. Increase in fibrinogen content. No, your fibrinogen will signal the clotting of your cells. Okay, that's why, no, when your red blood cell, no, sticks together, they will be heavier. So the ESR fall will be increased. Okay, increase hemoglobin concentration. Why? No? Why this increases the rate of fall? Because your RBC will be heavier. Okay? Heavier yung RBC mo because of the hemoglobin content. Next is the cholesterol. Your cholesterol, no, also increases the rate of fall. Why? Your cholesterol high density. Okay? So high density can affect the fall, for it will adhere to the sides of the cell, forming the high rate of settling. Okay? Other factor, intrinsic factor in your red blood cell, macrocytes, no, increase in size, anemia, decrease in count, no, anemia also can manifest macrocytosis, and hemolysis. Okay? Hemolysis can affect your ESR. It can increase the fall. Okay? Factors in decreasing the rate of fall of your ESR. Now we do have intrinsic, increased albumin, lecithin, and defibrillation. Okay? Increased protein, no, will decrease the rate of fall. Why? Okay? The This will promote, no, um blood viscosity. Okay? The blood viscosity will increase. Okay? That's why the rate of fall of your ESR will be decreased. Okay? Defibrillation, no? Hindi masyadong nag-perform ng rouleau formation ang yung mga RBC because there are no fibrinogen present in the plasma. Okay? Then you do have red cell factors like your microcytosis, increased RBC count, spherocytosis, and your variation in shape of your cells like your sickle cell and poikilocytes. Okay? We do have also in extrinsic factor, no? Prolonged standing of your blood, okay? Excess anticoagulant, temperature below 20 degrees Celsius. Why? Okay, the colder the place, the slower the settling of the cells. Okay? Short sedimentation tube, okay? Small bore of sedimentation tube, more blood specimen than your anticoagulant, okay? Presence of blood clots, and dirty glasswares. Okay, this decreases the rate of fall of your RBC. Mabagal ang pagbaba ng cells. Okay? Normal value for your ESR. So, in Western Grand method, usually this is being used in a clinical lab. Okay, for men, you do have 0 to 15 millimeter per hour. For women, 0 to 20 millimeter per hour. And for children, 0 to 10 millimeter per hour. No, higher degree for women. Okay? implications of this. Now, increased ESR can be seen in collagen diseases. Okay? SLE. Your SLE is systemic lupus erythematosus. Okay? Now, such disease can increase your ESR because of hemolysis. Okay? Because autoimmune diseases, no, possibly attacks some of your cells. Okay? Infection, no? Example is your pneumonia can increase ESR. Inflammatory diseases, okay, as said kanina, no? This ESR can be used in assessing inflammation. Okay, this can be a marker for inflammation, no? It can also be a marker in some cancers, no? Especially in lymphoma. This can also indicate toxemia, no? Presence of toxins in your blood, and anemia. Sometimes your ESR, no, are normal. Same goes with your RBCs. Okay? So this is found in sickle cell anemia, CHF or congestive heart failure. Your pyruvate kinase deficiency or PK deficiency can manifest normal ESR value. Okay, there is something wrong but your ESR is still normal. Next is the normal or varied ESR. Some acute diseases can manifest normal or increase or slight increase or decrease in ESR, like your acute diseases. Okay, musculoskeletal condition, especially those who are having no atrophy and uh, myo myopathies. Okay, cardiovascular infarction, no? Your MI can also manifest normal or slight increase in ESR. Okay, malignant diseases and acute allergies. Okay. Next, you have the morphological examination of blood cells. No? Morphology. So we will be focusing on the normal cell appearance of your RB blood cells in the peripheral blood. Okay, we do have different tests that uses a blood smear. That's why we are requiring you to have a perfect or almost perfect blood smear. Okay, for many of your tests, no, relays in the appearance of the cells in the smear. Okay. So first of all, you will use this blood smear in differential count of your leukocytes. So when you say differential count, okay, you will differentiate the types of WBC. So your WBCs or your leukocytes have five differentiations. Your neutrophil, lymphocyte, basophil, macrophages, and your eosinophils. Okay? You will distinguish these five and count them, no, until you will reach 100 count. Okay? That 100 count, okay, will correlate to the percentage of these leukocytes in the blood. Okay? Next, no, the blood smear can also assess normal, no, and abnormal cell shape and size. Okay, like microcytes can be seen, macrocytes, no, large platelets, okay. Immature blood cells can also be seen in blood smears. Reticulocyte count, no, you will need no a smear in reticulocyte count. Okay. Platelet count, no, indirect method, you will count platelets. using your blood smear, no, in 10 different fields. Okay, then use the formula in the corrected platelet count. Okay. Lupus erythematosus or your SLE examination can also be seen in blood smear. Okay, this SLE has a hallmark or cell that is only present in the disease. Then we also do smear in bone marrow. Okay, the bone marrow aspirate can be used in smearing, no, in assessing your blood cell production. Okay, so we have parts of your blood smear. Okay, this as seen in the picture, you have the slide. Okay, the head, no, compose the drop of your blood. So the drop of your blood is about, it should be about 2 to 5 millimeters, no, to have a perfect smear. Then the body, which has the dense, no, the dense area, masyadong makapal to. Kaya we will use the, no, morphologic zone or zone of morphology, which is um near the tail. Okay, this area will only be used in counting, okay, or even in cell differentiation. Why? Because the cells are has a normal spacing. Okay, and you can differentiate it um in good way. Okay, then the tail, no, fewer cells are seen in the tail. That's why we cannot also use this um in blood examination. Okay, the body has thick areas. You will notice that the cells are overlapping. Okay, overlapping cells, or even you cannot distinguish the content of the blood smear because of the um, thick, no, area. Okay, that's why we will use the zone of morphology for your blood cell differentiation. Okay, next. Okay, we do have preparation of your blood smear. We do have the manual method. Okay, we use manual method in preparing your blood smear. If ever that there is a machine, you can also use that. But normally here in the Philippines, we don't have any automated blood smear preparation. Okay, so in preparation of your manual blood smear, first, no, using your two glass slide, okay, or wedge method or push method. Okay, this is the simplest and commonly used in laboratories, or your slides are easily accessible to your personnel. Okay, the advantage of this, no, slides are not easily broken or thicker. Um, the slides has a thicker width than your slide cover, your cover slips. Okay, then this is easy to prepare, easy to label and transport. Okay, for it is larger than other glass that being used. Okay, this also allows, no, storage, and even without cover slip. Okay, kahit walang cover slip, pwede mo siyang i-store basta it is properly dried. Okay, then abnormal cells can easily be found because of your good distribution of the cells. Okay, because of the large, no, area that is being seen in a glass slide. Okay, characteristic of the good smear. Okay, there will be a characterization of your good smear. You can see if your smear is good or not. Okay, there should be a transition from thick to thin areas. Okay, there should be presence of the body, the body here, and the zone of morphology in the tail. You should distinguish these three parts, no? Now, the tail will have a rainbow morphology, rainbow appearance when being held against a good light source. Okay, that is the feathery edge that is being noted. Okay, the rainbow. Okay. Also, the smear should occupy 3/4 of the length of the slide. Okay, this is 3/4 of the slide because we don't consider the frosted area to be counted in the slide length because you cannot smear in the frosted area. You cannot see under the frosted area. Okay? Dapat 3/4. Kung kasama man yan, kung ang slide mo ay hindi frosted, it should be about this size. Okay? 3/4. Okay? Most of that has even surfaces, no? Free from waves, walang waving. So, yung mga nginig yung kamay, ito yung problema. Okay? It shouldn't have any ridges and even holes in it. Okay? Bakit? No? The cells are not evenly distributed. If you do observe this phenomenons, then white blood cells should not be bunched at the end of the edge of the smear. Why? Because yours said no, the distribution of cells are not even. You cannot identify if ever that the cell is increased or decreased. For some of your field will have increased no, cell count and some will have decreased cell count. No, unlike in a good smear, you will observe a good distribution of cells. Okay. It should have a feathery edge or tail as said kanina. It should have a rainbow no, when being held upon a good light source. Okay. We also use the thin smear. Okay. So parts of your smear can also be used in different types of tests. Okay, your thin smear is being used in WBC differential count or your leukocyte differential count. Okay, stain red cell examination, you can observe no, the cell morphology of especially the RBCs no, in the thin smear areas. Then you have the platelet count or the indirect method. Okay, the reticulocyte count and siderocyte count. Okay, even the malarial parasite count. The malarial parasite examination can use thick and thin smear. Okay, throughout the study of morphology of the blood cell. Okay, your thin smears, that is the one that being spread in the slide. Ito yon. This is the thin smear. Your thick smear, okay, is being used in malarial examination. So you will only drop blood and this is the slide. For example, you will only drop blood and will left it as is. Okay, that's the thick smear. No? Okay, we do have requirements to produce a good blood film or blood slide. Okay, we use clean glass slide and cover glasses. Okay, chemically clean. No? Clean, clean, clean. Bakit? It won't have any edges, no? Yung variation in edge. Okay, scratches. Then, um, we won't no use too large or too small drop. That's why no, the normal amount of blood that we use is 2 to 5 micrometer. No, yung point drop ng blood to produce a good shape of your smear. Okay? Work is done quickly before anticoagulation of the blood. Before the coagulation of the blood. Okay. Sometimes, no, you will encounter in the laboratory, the physician will say, we will inquire or require you to do a smearing bedside. No anticoagulant is needed. Why? It is more better that the cells are not that doesn't have coagulation, anticoagulant. Okay? Kaya meds okay na fresh yung blood na ginagamit, no, directly from the syringe. Okay? Yun yung ginagamit from smearing. But you can also use anticoagulated blood such as your EDTA and heparin. Okay, but we prepare fresh blood samples like your finger prick can also be used in the smearing. Then a proper angle and measure of pressure of the spreader. So the proper angle is ano 25 to 30 degree angle. Okay? So yung slide mo, so andito yung spreader. So this should be 25 to 30. Okay? Methods of drying the blood film. No. Commonly, we do air drying. No? We left the smear no, in the table or even in a good surface. Why? Dapat flat. No? Bakit? Kasi if your drying area is tilted, the cells will move to the tilted side. So you won't have even distribution of the cell. Okay, it can also be dry using heating or oven. Okay, but low for your blood cell can be um, unidentifiable if toasted. Pag natusta yung cells mo, hindi mo na syempre mababasa kung anong cells yan. Then, chemical drying using your ethyl alcohol. No, fixative for blood films. Bakit ethyl alcohol? It dehydrates the slide. No? Okay, it dehydrates the slide. Usually, ginagamit natin yan pag yung mga tinatransport yung blood films before special stains. Kung walang special stain na available sa laboratory, we will use ethyl alcohol to fix the slide. Okay? You will put this slide in a ethyl alcohol, then it will be transported into other laboratories. Okay. Other fixatives for your blood films. Okay, you do have methanol, alcohol, absolute ethyl alcohol in ether, no? Solution of mercury chloride, and formalin, 1% formalin. Okay? Most of them are alcohol or they are easily accessible. Okay, mercury chloride, formalin can cause no, um, some diseases. Kaya usually we use alcohol based. Okay? Okay. There are factors affecting the thickness and the thinness of your smear. No? First, syempre, the size of the drop of the blood being used. Larger drop, the thicker the smear is. Smaller drop, the thinner the smear. That's why, sinasabi talaga natin na dapat ang drop ng blood mo is 2 to 5 millimeters. Okay, to produce a good smear. Too large, too thick ang blood. And you cannot produce feathery edge in a large drop. Your small drop naman, you can produce feathery edge but too thin. Okay? Sobrang nipis na you cannot have a good number of cells in a one field. Okay. Another factor is the angle of the spreader against the stationary slide. Okay, the proper angle is 35 to 45. Sabi ko kanina, 25 to 30. Okay? But based on books, okay, that is 35 to 45. But on the actual practice, no, you will use 25 to 30. Okay? Bakit? Kasi mas okay yung smear. Good smear. No? But if you will ask on the boards, on the quizzes, you will answer 35 to 45. But on the actual practice, you will use 25 to 30 degrees. Okay? Okay, the increased angle, no, will produce thick smear. Decreased angle naman is thin smear. Okay? Other factors, no? Pressure in the spreader. Okay, heavy pressure, thin smear. Light will have thick smear. Okay, how will you assess if you have heavy pressure and light pressure? Wala. Okay, tansya-tansya lang. Huwag masyadong madiin, huwag masyadong light ang paghawak ng slide. Okay? Then the speed, too fast, you will have thick smear, and too slow is thin smear. Okay, wala ding measure kung gaano kabilis, gaano bagal mo i-smear. Basta, you will tansya. Tansya-tansya lang. Okay? Not that too fast, no? Huwag yung sobrang bilis na parang swift na ganon. Okay? Or huwag naman sobrang bagal na ganon. Bakit? Too slow can also produce ridges, no, waves. So, dapat smooth and maganda yung glide ng slide. Okay? Other methods being used in smearing, you do have cover glass method or the cover slip method or Ehrlich method. No? This is prepared in bone marrow preparation. Why? Because we will only use too small amount of your bone marrow aspirate. Okay? This is being used to distribute, no, the cells, especially your WBC or leukocytes, in the smear. Okay. The disadvantage of this, no, the cover slip is too thin. Sobrang nipis that it can be easily broken. Okay. This requires chemically clean cover glass and it is difficult to prepare. Bakit? Sobrang liit ng cover slip. Tapos doon ka mag-i-smear. Okay? Kaya ang hirap gawin nito. Okay? And your cover slip is too thin nga. That's why kahit konting pressure, it can be broken. It can also be difficult to label. Bakit? Too small yung space. And the stain and transport because of the fragility of your glass cover slip. Or cover glass. Next, we do have the BCOM method or glass and slide method. Now, there is even distribution of cell but yields limited blood smear. Okay. Then you do have automated method. The spun smear prepared in Hemaspinner and smear prepared in Mini Prep. So ito, you will just put the blood, no, using in the EDTA. Okay, EDTA, you will place it in the machine. Then the machine will prepare your smear. Okay, ang itsura nito is para siyang centrifuge. Okay? Okay. So after you prepare your blood smear, syempre, we will stain it. Okay. In staining your blood smear, we uses the appropriate blood stains. No, especially, we use your bright stain. Okay. Considered to be a plump polychromatic stain. Okay. When you say polychromatic stain, it has different components or color. So you do have the basic and the acidic component of this stain. So you do have the methylene blue acts as the basic dye to stain the acidic component of your cell. So ano yung mga acidic component ng cell? Your nucleus. Okay? Nucleus, RNA materials. Okay. That will be stained in methylene blue. That's why the nucleus of your WBCs are being seen as color blue. Next is your eosine, no? Acidic dye, which stains the basic component of your blood. Okay? That's why your RBC appears to be pink or red. Okay, because they are eosinophilic. Okay, they are basic. No, most of the time this is the cytoplasm of the cell. Okay, cytoplasm of the cell. Okay, RBCs are only cytoplasm. They don't have any nuclear content. That's why they are as eosinophilic cells. Okay. You do have also buffers, no, like your sodium phosphate, no, that has a specific pH of 6.4. This maintains the pH of the stain to have effective effect on the basic and acidic cells. Other stains, you do have Gemsa, Maygranwald, Leishmans, Jenners, and Panoptic stain. Your panoptic stains are a combination of Romanowski stain and another stain. Then you do have the supravital stain, as said kanina, in your reticulocyte count. It stains the living cells. No? In using supravital stain, you need to incubate the tube with the stain and the blood. Okay? For about 15 to 30 minutes. No? For the cells to accumulate the stain in the cytoplasm and the contents of it. Okay. In WBC differential count or your leukocyte differential count, no, we enumerate different type of your WBC using in percent. Okay, so we will count, no, we will count 100 WBCs, no, in different appearance or morphology. So you do have the steps, no, prepare blood smear, stain the blood smear, and then differentiate the leukocytes, then report the result. Okay? So, ano nga ba ulit yung binibilang natin dito? Neutrophils, lymphocytes, monocyte, eosinophil, and basophil. So, this is the normal distribution of your WBC from the highest number. So, your neutrophils has the highest count. Okay? Going to your basophil, which is the lowest count. Okay? This can also differentiate your agranulocyte and granulocyte. So your granulocytes are your neutrophil, eosinophil, and basophil. Those have granules. And you have then agranulocytes like your lymphocyte and monocyte, which doesn't have any granules at all. Okay, we do have different ways in scanning your differential count. We do have the strip or horizontal method. All the cells in a longitudinal strip from head to end of the tails are counted. So from the tick area, so if this is your slide, you do have this smear. From the tick area, you will count straight longitudinal. Okay, that's this strip or horizontal method. Then crenellation method, the cells are counted from the upper part of the smear, the lower part, then the sideways, then to the upper part until 100 cells are differentiated. So your crenellation method, okay, counted from upper part, lower part, side, side, and so on until you reach 100 count of the cell. Bakit 100, sir? Kasi nga, percent ang hinahanap natin. That's why 100 cells ang kinakount. Okay. Exaggerated battlement method. You do have the snake pattern. Okay. Either from tick or from pin in snake pattern. Okay. Two-field Mender method and then four-field meander method. Okay, ano yan? No? It will pick two fields or four fields, then compute for the cell count. So in assessing the counting, no, of your WBC, you do have shifts. No, shifting process. Ano ba tong shifting process na to? When we say shift to the left, okay, the WBCs that you are counting are more often seen in their younger forms. When you say younger forms, they are in blast forms. Bakit shift to the left? When you notice in counting using your counting chamber, no, not the counting chamber, the differential counter. Okay. Most of the cells, ano, may mga label yan. Di ba? Nakita na kayo nito. Okay, ito yung mga label. Then um, may label dyan ng cell. Kung ano yung cell, then yung count. Yung kunyari, yung 000. Di ba? Then gumagalaw yan. Okay. Most of the cells, no, on the left are younger cells. You will notice that. Then most of the cells on the right side of their differential counter is the mature one or the older forms. So when we say shift to the left, the numbers are increased in the left side of your counting differential counter. Okay? Bakit young? Because we have an increase in production of your cells. These are present in infections. Okay? Larger amount of your WBCs are needed. That's why we are producing large amount of WBCs, even in younger forms. Okay? Kaya, the blood smear or the patient will have a shift to the left. While you shift to the right, no, I said, older forms of your leukocytes. There are the mature ones. Okay? Seen in megaloblastic anemia, pernicious anemia, and even in convalescence of your infections. Okay? Tandaan nyo yan. Kaya right and left because of the arrangement of the cell in the differential counter. Okay, left, pagpabata. Right, pagpatanda. Okay? So, that's the end of lecture. Thank you. If you do have any question, you can raise it now.